Flourish for Life and Agile Life Sciences are bringing you a range of conversations. This week, we're focused on female health, specifically menopause, and asking the question, could we diagnose it better? Hi, my name's Bethan Hughes, your podcast host for today, and honoured to share a conversation with Dr. Jan Rogers and Dr. Helen Kini. Before we get started, I think it's important if the listeners learn a little bit more about you. So, Helen, over to you first. If you could just introduce yourself.
Hi, my name's Helen Kini. I'm an NHS GP and co-founder of Flourish for Life. It's a private clinic for lifestyle medicine where we offer individual appointments and also an offering for workplace. And it's been a perfect opportunity to combine my passion of 18 years of women's health, which I've done a lot of during my NHS career, and allow me time really to spend time with women to actually really help them through improving lifestyle and also improving their hormonal health. Done a little bit of a few conversations outside the individuals in different settings. So one of them was within our triathlon team, talking to the women around menopause and raising awareness around lifestyle medicine. And during that, I met Jan. So that's where we met, isn't it, Jan? So I'll let you introduce yourself before we have that story.
Okay, yeah, thanks, guys. Jan Rogers, so I'm the joint CEO of Agile Life Sciences, and we are developing a menopause test, which we'll go into a little bit later. My background, so I'm a scientist through and through, PhD scientist many, many years ago. Subsequently been working for both large and small companies, developing medical devices, and more laterally in vitro diagnostics. Our team is very much focused on life sciences. We're very passionate about what we do. And we also really wanted to sort of help, I think, find an unmet need, which, Helen, I think that's, again, sort of where we sort of first met. So I was on a podcast where Helen was chatting about menopause and the challenges, and challenges particularly around, I think, sort of, is there a test for menopause? And the answer is no. So it sort of got us thinking, really. And I think, again, Helen introduced us to the vaginal microbiome, which I'm sure we'll talk a lot more about later on. And that's sort of how we've sort of developed over the past sort of 18 months, really, researching in this space. So my background, I'm a scientist, not a clinician. So really sort of taking the sort of the listening to, I guess, the clinicians, the challenges that they have, and just seeing if our expertise can help in that area and help in that space with tests, diagnostic tests, monitoring tools and things like that. So that's my background.
Brilliant. Thanks both. So I think before we get into things, we've already just heard a couple of kind of key phrases, words, things that may or may not be familiar to people. So I think it's good if we just have a little moment to perhaps cover off some of the key terms and some of the things that we'll talk about today, just so that we're all on the same page. So Helen, I'm going to throw this one at you, if that's okay. So could you just give us perhaps a bit of an overview of, we hear premenopause, we hear perimenopause, we hear postmenopause. So just so that we're all kind of clear, could you perhaps define those in terms of both from a clinical perspective, but also what that means to somebody?
Yeah, I think it's important to think about a woman's journey, through her hormonal life. So every woman obviously has their own cycle, and that's obviously following puberty, and that's the premenopausal time. So they'll continue their cycle, and for women that can be irregular or irregular periods throughout their lives. And as they reach so that's really a reflection on your ovarian reserve. So your ovaries are producing eggs and you're getting this up and down, relatively stable, sort of hormonal fluctuation. And then as you get, as those eggs start reducing and depleting in number, you get this fluctuating of hormones. And during the perimenopause, so the time leading up to when your periods stop, you can have this fluctuating of estrogen and progesterone, and certainly estrogen, to sort of reducing, and it can actually have it can be quite a reasonable length of time. So it can be up to 7 to 10 years, up to the menopause. Now, the menopause itself is actually defined as a year and a day following your last period. And like for a lot of women, obviously that time before can be quite a tricky time and can be quite a transition. And I think it's probably quite important to, as a lot of us as women know, that we can have quite a lot of symptoms related to our hormones. And for some women, it can be quite sort of psychological symptoms, some physical symptoms. And so women can experience a lot of different symptoms during that time.
Brilliant. Thank you. And then I suppose as a follow-up to that, as a practicing clinician, what are perhaps the biggest challenges that you're faced with when women come to see you? And I think from the women that I've spoken to, there's quite a range. Some people are very aware about what's going on and that they perhaps are starting to think that they're entering that perimenopausal phase. But then also for many, they're just perhaps hit with lots of the symptoms, but perhaps don't have the physical marker of the change in periods, perhaps if they're on a coil device or something like that. So what are some of the biggest challenges when people come to see you?
I mean, I think it's a combination, isn't it? So I think you're right. There's a lot of women who are very self-aware. So and obviously, fortunately, over the last sort of 5-6 years, there's been greater awareness, hasn't there? And there's been a lot of campaigns for that, which has been brilliant. But yeah, so I think like back to what we described about the psychological and the physical symptoms, they're so individual depending on for those women. So it's whether women recognise it themselves, and it's also that lots can be happening at that time of life. So are women, blaming what's going on in life? Is it busy times? Is it work? Is it relationships? But also beyond that, are there other diagnoses that are going on? Because obviously a lot of symptoms can, fatigue, hot flushes, they can be a marker of other pathology as well as, perimenopause, menopause symptoms. So and for a lot of women also suffering with long-term conditions, that can also be another factor. So trying to work out the diagnosis of a perimenopause throughout that can be hard. And, for a lot of women, they do see a change in their periods. They can see and that can be a marker for a clinician who maybe isn't quite as a sort of aware of menopause, especially if, they haven't thought about that as part of their, differential diagnosis. But actually, if you put it all together, it's quite hard. It is quite hard. And so, in a lot of the current guidance, it's all on clinical symptoms. But if you haven't recognised it yourself, that makes it really
really difficult.
Yeah, absolutely.
Yeah. And is there a certain age that this all happens at, or is it?
I mean, the average age for menopause is 51, in this country. But actually, as we described, perimenopause can be 7 to 10 years up to that, that time. 1 in 1,000 women under the age of 30, 1 in 100 under the age of 40. This is something that can be really, really variable for every individual. And for some women, 1 in 4 women might not have any symptoms whatsoever. 2 out of 4 might have moderate. 1 in 4 could be quite significantly impacted. And I think it's has the woman herself recognised it? Has the clinician put it together? And going back to what I described at the beginning, unfortunately, we don't have a huge amount of time as clinicians, certainly in NHS, to be able to have that full conversation about the symptoms, the impact. And, both women and clinicians can jump to the conclusion that it's something else and go down an avenue. And I know certainly a lot of women do end up in secondary care for investigations around palpitations, headaches and everything, because actually a lot of the symptoms are quite variable.
Brilliant. Thank you. And so, Jan, how have you ended up in this space and working in menopause?
Jolly good question. No, so I think, as we mentioned earlier, really, we just the passion really around the life sciences, but also I think meeting that unmet need, and clearly menopause and menopause diagnostics and testing was becoming apparent that there was an unmet need, I think, and both from my point of view, both from a clinician's point of view to help them with that, aid that diagnosis, but also I think from the individual's point of view to just try and understand, am I perimenopausal? Because like you say, it is quite a challenge. So our expertise is very much life sciences. We were all very passionate about health and lifestyle, and the gut microbiome was something that we sort of, as individuals, we've all looked after and looked into. And I think ordinarily when we were looking for an opportunity, I think we'd have potentially gone down the gut microbiome, but it's just a very challenging environment. Which is why I think the conversation with Helen around vaginal microbiomes and diagnostic testing and the lack of thereof and menopause, sort of it all came together really around, how can we help in that space? So our test really is around looking at the vaginal microbiome. I mean, most people will probably be aware that hormone testing is quite a poor measure of whether or not you're you're perimenopausal. The MHRA and I guess NICE guidelines, don't recommend that kind of testing. It's really challenging to measure hormones it's not challenging to measure hormones from blood, but it's quite challenging to get a diagnostic of the hormone measurement in blood. And so that's, because it's fluctuating all the time. And so that becomes a real challenge. So we sort of looked at, will the vaginal microbiome be more stable environment? Will it give us a better diagnostic if we can get down that route? Will it just help us monitor where people are on that journey? So for the last 18 months, we've been researching in that space. And what we do is we take a urine sample and we measure the bacteria in that urine sample, and we can map that out by looking at the whole of the vaginal microbiome, so all the bacteria that are present in the biome. I think it's important to say that like the gut microbiome is very much diverse. It's all about the big number of bacteria that are present. The vaginal microbiome is completely different, so it's all about the dominance of one type of bacteria, and that bacteria is lactobacilli. However, there are different species of lactobacilli, and lactobacilli is dominant because of the amount of estrogen. As Helen said, through that phase of premenopause, estrogen's abundant. It keeps the vagina in a very low pH. And the only bacteria that can really survive, the good guys, are the lactobacilli. So you have a very healthy vaginal environment. As estrogen starts to reduce, which it will do as we enter into perimenopause and then into postmenopause, where it ceases altogether, what happens is the pH changes slightly, and different types of lactobacilli bacteria can then start to proliferate in that vaginal environment. And really, that's what we're monitoring. We're monitoring the change from, a high level of lactobacilli crispatus, which is the really good guys, to the other different species, which is Inas, Jensenii, and Gasseri. And as we can sort of measure those ratios and how they change, that's really what's giving us guidance on whether or not people are entering the perimenopause and not. And it very much a research phase, but we're seeing some really positive data.
Brilliant. Sounds really exciting.
Because that's really where we have the complexity with diagnostics, don't we, in our clinical space. So over the age of 45, the NICE guidelines suggest that we don't do any hormonal testing, and prior to 45 that we can do bloods. But even with normal FSH levels, so follicle stimulating hormones, so that's showing that the brain's trying to stimulate those ovaries to release eggs and create that cycle. A lot of women in their perimenopausal phase have completely normal blood tests, but can be quite symptomatic. And there are a lot of women that at that stage get dismissed, clinically. And I think that's where there is a lot of frustration from individual women, because they know something's happening. Something's changing. And in the menopause sort of specialist area, people are proactively treating that with good results for women. But this would help, I think, potentially.
Exactly, yeah. And I think absolutely is. I think because the estrogen reduction is happening, and we also know it's fluctuating. It's kind of like a spiky little downward trend, if that makes sense. And so because it's a downward trend, the bacteria sort of, they're far more stable. They will grow in a slightly different environment. So we can start to measure the differences between, as we switch from Lactobacilli crispatus to Lactobacilli Inas, it's like, okay, there's a change that's happening. And obviously there is this kind of prescribed route through research that's already been done. We've sort of reviewed all of that, and really we're just taking that and just applying it now to a more specific environment, which is the menopause environment. So,
but back to what we were describing about all those different things that can be happening in a woman's life, clinically, I kind of think this could be so useful for us working in a busy clinic, or just to add to the clinical, sort of conversation, the gathering of the history and patients tracking, and then putting it all together to help really guide us.
Yeah, no, absolutely. Yeah. And I think, that the hope for us, I guess, is obviously that it helps clinicians, not as a diagnostic, but as sort of you know what I mean? It's another little step. It's another bit of information that might just help them get to that point, I guess, a little bit earlier, or even feel a bit more confident that actually what their thought process is actually, oh, okay, it probably is menopause, and there's a confirmation that it potentially is, I think. But I think there's the whole how can you monitor it, I guess, to a certain extent? So, is the treatment pathway that and again, I don't want to put words into clinicians' mouth, but my thought process is, is the treatment pathway that's been prescribed, can I measure it to make sure that actually it is working as we expect it to work? So, the vaginal microbiome is becoming more dominated by lactobacilli again. I think that's key to it.
I think that'd be really exciting if the research shows something, because that's one thing that we are reliant on. And obviously it's important to treat symptoms and obviously if they're improving, but because they can be so complex and diverse, the symptoms themselves, I think a lot of women see a bit of improvement, but they do mention other symptoms and you think, are they related? You're on hormone replacement now. So potentially that could be quite exciting. It'd be interesting to see what the research shows on that. So,
so that would be taking out perhaps some of the, I don't want to say guesswork, but your kind of gut feel for perhaps a diagnosis at the moment. It would give that confidence, and perhaps from a woman's perspective, that confidence sooner as to what they're going through. Because I think, from what we hear, that many women will perhaps visit their GP on multiple occasions before, and almost trying to rule out other things before thinking of menopause or ruling that in. So perhaps that might obviously be beneficial for you as a GP who's got a waiting room full of patients, but also from that woman's perspective.
Absolutely. And I think, the recent, the APPG, what was it?
The All Parliamentary.
That's right. Sorry, using an
the All Party Parliamentary Group. That they looked at menopause for a good year, and they've recently published their guidance.
I think they actually described, didn't they, 9% of women presented to their GP over 10 times before getting a diagnosis. So, even that, would be able to save us a huge amount of time. And I think back to Jan's point about actually helping women understand that this might be part of the story. Obviously, people are complex. It could be a variety of different things. But I think, I speak to a lot of women that they haven't even considered it.
Yeah.
So actually trying to create that understanding and that awareness that this might be part of it is really important, because obviously, I think we're going back a step, but to education, I've spent 18 years, absolutely loving female health and women's health. So I've kind of, done a lot of extra training and I've just been fascinated by it. But for a lot of us, certainly in my, medical school, I wasn't taught about menopause. So I know that's changing now and hopefully there's going to be a big shift. But there's a lot of us out there as clinicians that just, I much as we should.
And I think that was the other really interesting thing that came out in that report, that I think it was around 42% of medical schools actually don't cover this. And I think, often we hear in the media, people are really quick to bash GPs for perhaps not supporting women, but actually who are supporting the GPs to ensure that they've got that level of education and training as to, what they should be looking for.
Absolutely. There's lots of education now, and I think there's a lot of people that have signed up and are engaging with it, and there's some huge support out there now. But actually, like you say, there's the shift is happening, but it's going to be slow, isn't it? So I think anything that can help us in that space would be really useful. And obviously, it's going to happen to 100% of women.
Yeah.
So it's massive. And
that's 51% of the population.
Absolutely. So. And I think, beyond healthcare, just thinking about the impact into workplaces. So, within Flourish, we do quite a lot of work supporting workplaces. And that, again, has been that opportunity to educate, raise awareness, and actually talk around both the hormonal aspects of menopause, but also the lifestyle aspects. And, 1 in 10 women will potentially leave their job or, look at a change in role due to, during the menopause. And as they say, it was due to those reasons that they left. That's huge.
And I think that's kind of, sort of perceived as, the job that I've done for the last sort of 15, 20 years, I can no longer cope with, and start to assume that the job has got more pressures on it, that, that as it's become more challenging, the environment's become more challenging, when really, like you say, it could just well be the individual going through the menopause, and with the right treatment pathways, with the right, I guess, with the, with more understanding in the workplace. Those women will stay in those jobs for longer, and that will potentially impact on the
economic situation.
On the economic situation. Yeah, exactly that. Yeah, it's massive, really, when you think about it.
It's huge, and I think again it's down to that awareness, that understanding, that making it acceptable to talk about it, and I'm hopeful that all these conversations just help towards that, really, because we haven't been talking about it, have we, as women individually or with our patients as much as we
No,
should.
yeah, absolutely, yeah. I think we all, I think we all are mums that kind of, you just get through it.
Yeah, I mean, I spend so many times with patients that actually feel it's a failure to consider hormone replacement, or, I mean, obviously it's probably beyond the scope of today's podcast, but talking about actually sort of the concerns that people have had around hormone replacement, over the years. So obviously a lot of the anxiety and the worry about hormone replacement came from the likely sort of misinterpretation around data, from the Women's Health Initiative, wasn't it, in 2002?
And over 20 years ago, wasn't it?
It was over 20 years ago, and I think
it's still a legacy.
Absolutely.
It is, and overnight, I think women put their hormone replacement in the bin, and clinicians stopped prescribing. And I think we're sort of still unpicking all that, and obviously we're using, body identical hormone replacement, through nice guidance under the, sort of support and guidance through places like the British Menopause Society, and we are prescribing in a really safe way, and actually the risks are really quite low. Obviously not everyone can take hormone replacement. I think it's important to talk about that group as well, and I think actually around that, I think this is where your potential research could be helpful, isn't it? Because obviously one of obviously as a GP with an interest in menopause, you use a lot of hormone replacement as well, but we also obviously with the interest around lifestyle medicine using we're both great believers in that, aren't we? Improving aspects of sleep, exercise, activity, nutrition can be hugely beneficial for people. So do you think we'll be able to see that sort of improvement from the lifestyle perspectives with your vaginal?
Absolutely, yeah. And I think, there's a little bit of research in that space, but not a huge amount at the moment. And, again, we're very much about, filling in that gender research gap and making sure that, we do focus in on this space. But, if you take the vaginal microbiome, there are two key things that really influence it. Estrogen and hormones are obviously one, and we don't have the control because the estrogen is going to be reduced. Now you can replace that with HRT, like you say, but the other one is the immunity and then the inflammatory markers that comes with it. And that can be monitored and improved by, like you talk about, the sort of lifestyle medicine, which is, good sleep, a good diet, a good exercise regime. All of those things will help maintain your inflammatory markers down, which will also influence on maintaining a good vaginal microbiome, particularly as you get older. So, if we talk about the postmenopausal women, typically they have a very dysbiotic vaginal microbiome, which means there's a lot of different bacteria there. It's no longer dominated by that lactobacilli. And as a consequence, it makes you more at risk of UTIs because the lactobacilli is a very protective bacteria. It has very hostile environments and doesn't let any of the bad guys in, basically. But as you reduce the estrogen levels and the lactobacilli starts to diminish, then, the bacteria, different bacteria can proliferate, and in some cases it could be UTIs. So we do know particularly as women age, they become more prone to UTIs, and that's one of the key reasons. So, there is a discussion, a debate, and I'd love to know your opinion on it. Is there value, I guess, in people maintaining that hormonal replacement therapy sort of into older age, into post menopause? But also, the key is also maintaining that good lifestyle, isn't it? We know as you maintain that good lifestyle, if you can maintain a good vaginal microbiome, it massively helps, I think.
Yeah, I think there's a few things to pick up on there, isn't there? Because I think obviously lifestyle medicine and improving lifestyle is good for all stages of a woman's life, isn't it? And that helps. But actually that postmenopausal time's really key. And I can't tell you how many women who struggle with recurrent water infections, and you suddenly at some point pick up and you think actually, and it can be transformational to treat it with topical estrogen, and then suddenly the recurrent UTIs start settling down, and it's massive. But to be able to monitor that would be potentially really helpful. I think also to give people confidence, with regards to, and to see how much improvement's being made would be useful. I think the challenge we've got is around that is to help women understand what's happening, because I think obviously, like you mentioned about continuing hormone replacement throughout, so I think your needs for estrogen actually change, don't they? So during the perimenopausal stage of life, you can be having quite these big fluctuations of hormones, and actually some women need quite high doses of estrogen to actually settle symptoms and help. But as they go through to the postmenopausal time and your estrogen levels are naturally dropping, sometimes those more systemic, really sort of more hot flushes and the kind of more significant, even psychological, physical symptoms do settle slightly. That can, on average about 3 to 5 years afterwards, but obviously every woman's different. But the postmenopausal fact is your estrogen levels are low, and the sort of symptoms that can affect your vaginal area, your vulval area, bladder area, they become more prominent. So, I've got a lot of women who actually reduce down their need for, systemic or, HRT through their patch, gel or spray, and then they actually just use topical treatment. And some women who, because of their symptoms and choice, they continue on hormone replacement long term. So I think to potentially consider ways of being able to individualise that for women through both lifestyle and maybe through hormone replacement would be really helpful.
Definitely.
Brilliant. So, Jan, I'm a bit simple. One of the things I'm sat here thinking is, how do you analyse internally my microbiome from a urine sample? Do you not need some sort of swab or something to take some cells from, internally?
Yes, I think I get what you're talking about there. So because we're taking it from the urine, so we're measuring the bacteria. So we're not really looking at the human aspect of this, to be honest. We're just interested in the bacteria that are existing there. So we don't need to scrape any human cells to test the bacteria, because the bacteria, they're kind of just, they're existing in there. You can collect them using a swab.
Yep.
Undoubtedly, I think. We felt during our development that urine is easier, it's more inclusive. So it's because we send the sample off, we've got a little device that you use to pee into, and we can collect the exact amount that we want, and it's always from the first pass of the urine, or the first catch of that urine. And that's critical for us because, to your point, Beth, we do need the bacteria to be flushed out. So the longer... Sounds a bit weird, but the longer it's kind of been sitting there, the more that's going to be flushed out, because the bacteria kind of like to flourish and live in that environment. So as you urinate, you will flush out from that space, and then from the vaginal space as well, and we capture that. And then what we can do is we can we basically bash all the cells up. We take just the bacterial cells, and we use a technique called next generation sequencing. And from that's how we can differentiate between these different types of bacteria. But not only can we differentiate between these different types of bacteria, we can also measure their relative abundance. So how much is there? So we know that if you've got 75% Lactobacillus crispatus, bingo, that's really good. But also, if you've got 75% Lactobacillus crispatus, you might have 10 or 20% of what we would call pathogens, bad bacteria, which if you used a different technique, perhaps you would identify those and maybe even treat them, because they will amplify. You will be able to detect them. But using our technique, we now know that there's only 10% there or 15%. So we know the good guys are completely keeping them under control. They're in their box. They're not doing anything. So we can use the urine sample. The benefit is to be debated whether it's a benefit, but one of the key benefits of using a urine sample is de facto you will measure UTIs, so urinary tract infections, to the species level. So again, it will potentially give you a better understanding of what the UTI is. If it's a recurrent one, is the same bacteria coming back time and time and time again? In which case, is there a better antibiotic? It will estrogen again, because we know estrogen just really helps the good guys proliferate. Is that sufficient? So I think, so we're comfortable with urine. We're going down the research route. I think there are research publications between urine and swab. But there, I do appreciate I think there may be a slight complexity in trying to understand, but as we can measure the vaginal microbiome, and that is representative of the vagina.
Thank you. And I guess from a a woman's perspective, it's much easier to get a urine sample than perhaps swabbing themselves, and I guess less room for error from...
I think so, yeah. I mean, we all know, the classic example, and now we can reference COVID for everything, which I think is great, but we now know, you know if yourself, when you took the COVID, some people completely, down the back of the tonsils and tickle the tonsils, and it was very unpleasant, or, up to the eyeballs when they were doing nasal pharyngeal. And some people just, sort of just almost got as far down, as far as they could. And some people found it very difficult to do that test as well. So undoubtedly you were getting differences in some of those tests that we get. So I think it's going to be the same with the vaginal swab. They can say how far you insert it. Everybody's different, 2 centimetres, 4 centimetres, 6 centimetres.
Well, also, it could be quite an uncomfortable place at this time of life as well, couldn't it? So I've got a lot of ladies who struggle with vaginal dryness or soreness. And if we're talking in the postmenopausal space, that can... I don't think that would be very tolerated. Thinking about examining women at that time, they find it really uncomfortable. So
definitely, yeah. So I think we felt that urine was more inclusive, and the data that we've got to date, shows it's absolutely comparable to a swab. So
and potentially something you don't need to be in the actual clinical room for.
Yeah.
So it could be something that's done, I guess, prior to a consultation or following a consultation that's done at the woman's time rather than self-swabs or
absolutely
like that.
I mean, the testing, the sample collection, and again, COVID's been great for this because it's made people more comfortable with actually popping a tube in a post and sending it off and doing a swab at home. And so collecting a urine sample following the same process, I think hopefully it's made it a lot easier for people.
So that's how it works. You send somebody a kit, they do a sample and send it back to you.
Exactly that, yeah. So we have a kit, and in that kit there's a little urine collection device designed specifically to collect urine. I don't know if anybody's familiar, it's a little bit like a shiwi, so a little bit like a funnel. As I say, it collects just the first 10 mils and then discards everything else down the loo. You literally take that tube off, pop a cap on, pop it in the post, send it to us, and then we do the testing. And then we've got a report that sort of our GPs review, and it goes back to the individual.
So it sounds really exciting, and I think with lots of research that we hear about, we're kind of like, oh, so when's it going to be here? How soon can I use it? And Helen, from your perspective as a GP, there's probably a little bit of you that's like, this sounds amazing and potentially game changing, but we have to have a dose of realism and.
It's early
can you
days.
see it working? And
I'd like to. I think there's still lots of questions, aren't there? And I think everything with new science, new research, I think it needs to be rigorously tested. We need to be asking lots of questions, asking what actually may or may not be. You can conclude from the research that we find. So I think it feels like early days, but exciting. From a NHS perspective, obviously. Resources are, limited. So I think it needs to really, have value. It needs to be adopted. It needs to be, again, tested, improved. And I think we're at that stage of the beginning of that journey, really, aren't you?
I think that's exactly where we are. So, yeah, we've started a pilot study. Mm-hmm. We're looking to recruit 1,000 women. It's a very simple inclusive. It's age 38 and over and assigned female at birth. Mm-hmm. And that's really to give us a good set of data for pre, peri and postmenopausal women to have a look at how their vaginal microbiomes, how different they are, I guess, within those populations. We've got a bioinformatics group working on the data. So again, I think, we're going to really drill down on what this data looks like and really try to bring in some good understanding in this space. So we really want to get some good publications into the public domain on this to really sort of support, I think, the clinicians who probably, dare I say, are the most sceptical without a doubt and our most challenging group. Yeah. But also, I think it's important that we look to get a product to market that can start to help people understand where they are. So it may not be a diagnostic test in the first instance, but I think, it will hopefully guide people on that journey. And whilst we gather more data really to sort of really support the evidence-based around making it into a diagnostic test.
So a couple of final questions before we wrap up. So if I've listened to this podcast and I'm thinking, I'm over 38 years of age, and I'm, female at birth. Where do I sign up to help the research?
So at the moment we are in our pilot phase. So we are accepting up to 1,000 women into the pilot phase. That test is free of charge because it's our research. You would sign up on our website, which is MenoGuide.co.uk. And you can sign up there for our pilot trial that will come through to us. And we will, we'll send the sample out to you and then just follow the instructions and return it, basically. Fantastic. I guess it's important to say at this moment in time then, it's research, so it's not a diagnostic test.
Okay.
But you will get the report, you will get information back, and you'll get some signposting as well as to how to go to the next stage if that's what you want.
Mm-hmm. Great, thank you. And Helen, I'm interested to know a little bit more about your work at Flourish. So, talked about lifestyle medicine and kind of the various sort of impacts that can have. So how could Flourish help me sort of, I guess, be better at some of the things that we've talked about in terms of perhaps, sleep and nutrition, or I just want to come and see you because I've listened to you today and I think you might understand me, or you might get me, and you might understand kind of what I'm going through. How does it work?
I mean, lifestyle medicine, it's probably worth just covering that really. So lifestyle medicine itself is looking at the pillars of lifestyle. So that's physical activity, sleep, nutrition, connection, relaxation, and stress management, and looking at reducing harmful substances like alcohol, smoking, drugs, And the idea is you look at every individual, as a whole, and we know that all of us have all those different aspects of our lives we're juggling, and look at how can we look at those pillars and optimize for you what's relevant. So say if you had difficulty sleeping, we'd look at the science of sleep, the evidence around sleep, interventions and support and advice and things that we could change. So we do a lot of work around behavioural change and support, understanding that where you're at is where you're at, and how can we help you move to where you want to be. Yeah. So we use, within Flourish itself, we've developed a team. So we've got a trusted team who are all trained, at high levels in their field. So we've got, sleep specialists, nutrition, experts, and we use a lot of work through coaching, health coaching, and it allows individuals to actually be able to achieve the goals, or achieve the lifestyle prescription, if you like. And alongside that, say if you have got any hormonal challenges, or you're looking at possibly optimizing your or considering hormone replacement, that's something that we, as I say, it's important to consider altogether, really. So from my perspective, I see individual women, and it's a very different environment to the NHS, but it's a lovely, got time, which is amazing, and I've got like 45 minutes where I can talk through. We have quite a thorough pre-assessment form where people fill in a significant amount of details around their lifestyle aspects and their history of their hormonal health, and then we gather it all together in a conversation, and then we create really together a shared management plan around hormonal interventions if required, or a conversation around that menopause journey if needed, or whatever the situation, really, because obviously lifestyle medicine can apply to all aspects of life, but and then we go through the different pillars and actually make that specific to you. So we make it achievable, one change, and it's been that's pretty much what we're doing around the Flourish thing, or into workplaces as well. We can talk to big workplaces around the concept of lifestyle medicine too.
Yeah, and there's lots of companies looking out at the moment in terms of how can we better support our employees, and a happy, healthy workforce is a productive workforce. But I think everybody's appreciating that everybody needs support, and actually, the power of the collective as well. So really, really fascinating. So thank you both for joining us today. I think, we've touched on many things, and I think there's certainly more that we could talk about perhaps in the future. We've already sort of just skimmed the surface, I think, of this menopause discussion. And I'd really like to keep this going. So hopefully we can do some more of it in the future. So thanks both for your time today.
Yeah,
thanks very much. Thanks, guys.